Welcome, everyone, to Creating a Family. Talk about foster, adoptive, and kinship care. Welcome back to our regulars and a special shout-out welcome to our newbies. And just a reminder to everyone, we are now on YouTube, so if you want to see us in person and see our esteemed guest in person, you can check us out on YouTube. I'm Dawn Davenport. I am the host of this show as well as the director of the nonprofit, creatingafamily.org. Today, we're going to be talking about common special needs in international adoption, and we're going to be talking with Dr. Dana Johnson. He is a professor of pediatrics in the Division of Neonatology at the University of Minnesota Medical School. He founded the International Adoption Clinic at the University of Minnesota, and he is a dad and a granddad by both birth and adoption. Welcome, Dr. Johnson, to Creating a Family. We are so glad to have you.
It's just delightful to be with you again, Don. I enjoy speaking with you and with your audience very much.
Well, international adoption has become overwhelmingly a special needs adoption program from all countries now. It didn't used to be, and I think people sometimes don't realize that truly that is what it is now. And we're going to talk about what we mean by special needs shortly. But prospective adoptive parents are required as part of the adoption process to fill out a form on what special needs they will accept. And by what they will accept, what we really want them to focus on, are they the best family for this child, both at the short term as well as for the long term. This interview is intended as an initial overview to help parents know what they need to research further. So after you decide which special needs would be the most possible good fit for you or your family, you then need to do further research to learn more. All right, we're going to start by going through the most common special needs in international adoption, what they are, and how involved they are in post-adoption care. Then we're going to move to cover the most common special needs you will see from the major placing countries. So, without further ado, let's jump right in. All right, one of the most common special needs is cerebral palsy. What is cerebral palsy, and how involved is it for families and for the child?
Certainly. Cerebral palsy really is one of the most common special needs that we see coming from other countries. And loosely defined, cerebral palsy is a fixed motor disability that starts during infancy and generally is non-progressive. So what I mean by that is that it primarily affects the motor system and not cognitive abilities, although there is a blending of cognitive and physical disabilities in the more severely affected kids. The other thing about cognitive disabilities is that if one side of the brain is affected more than the other, you do see cognitive disabilities in those kids as well. It used to be thought that cerebral palsy was primarily related to problems during gestation and the delivery process. For instance, a baby didn't get enough oxygen and was asphyxiated at the time of birth with very low APGAR scores. We know now that it's a much broader situation than that, and that genetic components also may lead to the development of cerebral palsy as well. The difficulty with planning on parenting a child with cerebral palsy is that the spectrum is extremely wide. So it ranges from kids who have very minor motor problems that only a pediatric neurologist would be able to pick up. They're fully functional, cognitively able, and really blend in with the general population very well. And it goes all the way to kids who are totally dependent on parental care and severely cognitively disabled. So I think that, that's one of the difficulties that parents face.
But with a referral, when you have a referral, would you not have that information at the time or not? And we're not getting, for the most part, newborn infants. So how much information is available?
Well, the more the diagnosis becomes easier and the prognosis more certain, the older the child is. So if you are referred a 4-year-old with cerebral palsy, you can pretty much guess what the future might hold for that child. If in rare circumstances you are referred a premature infant who is 6 months of age, it may not be readily apparent because they have not made very many motor milestones by that time, exactly how severely affected they might be.
Yeah, that makes sense. All right, let's move on to another common special need, and that is heart issues. And that is a hugely broad category, I realize. But if you can hit the high points of what to look for in making this decision of whether you're the right family for a child with heart issues.
Certainly. Heart issues are very common. In the general population, probably 2 or 3% of kids will have some type of congenital heart problem. Most of them are minor problems or problems that are easily fixed with surgery or even non-surgical means. Others are more complicated and involve lifelong issues that need to be followed by a pediatric cardiologist. So your usual small holes in various parts of the heart, atrial septal defects and ventricular septal defects, generally are fairly straightforward in terms of care. If they need surgery, that can be done relatively early in life with very low morbidity and mortality. The more complicated ones that involve abnormalities of the great vessels, abnormalities of the drainage of the pulmonary venous system are much more difficult to take care of, although the progress that's been made over the last 20 or 30 years has been pretty remarkable in terms of how well these kids do. What I would say about heart problems is that they should contact a pediatric cardiologist. Usually the information we get about heart defects is pretty complete. So there are echo reports that will tell you what the structure is. And from that, a good pediatric cardiologist can tell you what course of treatment might be available and whether or not there are going to be future disabilities that might be considered.
And something I would also suggest is note how close you are to a good pediatric cardiologist or to a center that does the surgeries, that does follow-up care. Because if you're located a far distance away, you need to factor that in to your life. Do you have the ability to have a child that is being brought for regular checkups, and the distance is in hours versus minutes? So
Exactly.
something to consider. All right. What about craniofacial issues? And I realize that this is a broad category, but if you could tell us in general what you're seeing.
Well, the most common craniofacial issues we see are cleft palate and cleft lip. And the one thing I would say is that both cleft palate and cleft lip are associated with other malformations in other organ systems, but the one that you should think of with a distinction is that children with cleft lip and cleft palate tend to have fewer abnormalities in other organ systems than children who have cleft palate alone. There are centers around the country at pediatric hospitals that deal with craniofacial malformations. They can be extremely complicated, involve most of the bones of the skull as well as the face, and require a multidisciplinary team of craniofacial surgeons, ENT specialists, and a team of audiologists and speech and language pathologists to fully rehabilitate kids. But it's pretty remarkable at what can be done with kids with craniofacial malformations these days. Certainly, if a child has a cleft lip and cleft palate, there are a number of centers around the country that are certified by Cleft Lip and Palate Association. They have the teams necessary to totally rehabilitate a child. And really, it's pretty remarkable, both in terms of the physical appearance of a child with cleft lip and palate, as well as the functional abilities in terms of speech and language, swallowing, chewing, and generally getting along well with the peer group.
And again, the operative thing that I heard you say was that it's a lot of progress has been made, and these kids can do very well, but they do better when they have a team approach for their rehabilitation, surgery, and things such as that. So find out where such a center is in relation to where you are located, and make a decision based on that.
Exactly.
All right, now let's talk about developmental special needs, both in general and then specific autism and Down syndrome.
Sure. Let me talk about Down syndrome, as I think most people are pretty familiar with. and I've met kids with Down syndrome. Very common chromosomal abnormality and extra chromosome number 21. There are a number of problems that these kids can have. Basically, abnormalities of all major organ systems, heart, kidneys, gastrointestinal tract, etc. Cognitive disabilities are universal in kids with Down syndrome. They all have cognitive disabilities, some worse than others. It's very difficult to predict at the beginning how severe the cognitive disabilities are going to be, but these kids are going to require some degree of parental involvement for their entire life. They may be able to live in independent living situations with supervision later on in life, but adopting a child with Down syndrome means that you're going to be a parent for the rest of your life. This is not a situation where you're going to send them off to college and let them go on their own. Mm-hmm. Yet it's very, very common for parents to want to adopt children with Down syndrome because they are wonderful children. They're loving and extremely warm kids and add a great deal of spark to the lives of families. Mm-hmm. There are ongoing issues. Again, the American Academy of Pediatrics has well-developed guidelines for medically following kids with Down syndrome. For instance, these kids have a high incidence of hypothyroidism that require treatment. And then probably the most common thing is that they have hearing and speech problems and need to be followed very carefully for that. So again, as Don has mentioned, find out what the resources are in your community. Many hospitals will have Down syndrome clinics that will follow these kids very carefully and provide the care that they need. And also make sure you check on your health insurance. Again, the kids require a lot of medical intervention, and consequently, you want to make sure you have good medical insurance, not just for surgical procedures, but also for rehabilitation services. Physical and occupational therapists make a big difference in how these kids do.
It's a good point. In general, if you are thinking of adopting a child with special needs, lower your deductible.
Exactly.
Yeah, just in general. All right, what about autism? How common is that? How common is it diagnosed in children who are being placed internationally?
Well, I wish I had numbers for you about that. So the incidence of autism, as everyone has heard, has increased dramatically over the last 20 or 30 years. Now, much of this is due to different ways of diagnosing and increasing the spectrum that's considered autistic. But there probably is some real increase, probably from environmental issues in the incidence of autism. Autism is like cerebral palsy in the sense that it's a very, very broad spectrum. You can have people who are completely functional, but lack the ability to interact on a personal basis that would fit into an autistic spectrum. And you have children who are profoundly cognitively impaired with severe behavior problems that require extraordinary intervention, who are also on the autistic spectrum. So again, it all depends on how severe it is as to how well families will do. The earliest that autism is currently diagnosed, although people are working on better methods to diagnose it as an earlier age, is around 2 years of age or a little bit older. Some kids aren't diagnosed until they're 4 or 5. The reason that we want to diagnose it early is because intervention does help. And so the earlier the interventions can begin, the better off the outcome can conceivably be. But the incidence in children who are adopted probably is the same as it is for the general population, with the caveat that when we saw kids coming from Eastern Europe, especially from the Romanian orphanages where they were very poorly taken care of, there was an entity that was named institutional autism or quasi-autistic behavior that occurred in these kids. It looks just like autism, but by the experts that looked at these kids, probably wasn't due to the same things. It was probably due to profound neglect within the orphanage environment that these kids have. So you can see it in situations where children are profoundly affected by the environment. It's probably different than regular autism we see in the general population. But we're not seeing kids coming from orphanages that are as bad as that. So we are not seeing that now.
Yeah. Well, that leads us straight right into talking about developmental delays, because that's a hard one, because we know that children who are coming from child welfare institutions often haven't had the stimulation or the experiences, very often have experienced neglect, abuse, whatever in their prior life. All of these can impact their development and delay their development.
Exactly.
So how do we know when we are a child we're looking at is 5 and is and their referral says they're functioning on say a 3-year-old level? How do we know how much of that is caused by the fact that they have never had somebody sit with them and induce string activities or whatever and exercise their eye hand and their pinchers and things like that, versus the fact that this child might be developmentally delayed?
Sure. So we have a fairly good idea of the progress of delays, the time course of delays within institutional care. So we know that in terms of motor development, kids are very developmentally delayed until they start being able to move themselves around. So by 10 or 11 months, kids are able to get around the crib, stand and walk with assistance from holding on. And they make great developmental gains after that. So by the time they're 18 to 24 months, they generally, in terms of their gross motor activity, are in pretty good shape. Their fine motor activity may delay a little bit, but if you see a child at 3 years of age who is profoundly motor delayed, that would be unlikely due to living in an orphanage. They also have significant speech and language delays up until maybe 2 or 3 years of age, where they start catching up. They are probably not age appropriate, even when they're 4 or 5 in terms of language, but they're able to communicate more. So by the time a child is 5 or 6 years of age, their motor skills and their language abilities should be not age appropriate, but perhaps they're functional at that age. And so if you see kids that are profoundly developmental delayed in any of the areas, it's unlikely due to a neglect that we see within institutional care. It's much more subtle at that age when we think of institutional delays.
Okay.
So again, developmental delays can be severe, they can be minor. What we get when we get a referral is kind of a snapshot of where the child is at that particular point. So what we like to see is some type of an evaluation that repeats itself over the course of time. So, for instance, a child is in an institution for 15 months and then gets placed in a foster family. So we'd like to see a report at 15 months and see what they can do. And then we want to see what happens when they get put in that foster family, how rapid the improvement is. Because the environment of a foster family is going to be much more nurturing than the environment of an institution. And if we see tremendous improvement when that child is in the foster family, then we can be pretty certain that the delays that we saw in the institution are due to institutional care. If we have a child who's been in a foster family for their entire life and still has significant developmental delays, then we're more concerned that those might be developmental delays that are going to be ongoing. What I like to see, and most countries will be able to do this that are placing now, is a formal developmental assessment done by a psychologist and a team of occupational and physical therapists that will tell us what the abilities of that child are based on the norms, so that we can get what would involve a kind of an infant IQ score on how they're doing. You know, if they fall somewhere within the normal range, we know that they're likely to improve when they get into their adoptive family. If they're way below the normal norm, then we start worrying that there probably are some disabilities that are involved in that delay that may be permanent.
Let me pause this terrific interview right now to ask a favor of you. We are dependent on you guys to let others know about this podcast. And the best way you can do that is to give us a rating on whatever app you use. It can be Apple, Spotify, and YouTube. It's less of a rating and you just make a comment. But we really need these ratings because that's how the apps, they use the ratings and in particular the written comments in order to suggest podcasts to others who are looking for, if they type in the word adoption, or in this case, international adoption. We would get ranked higher depending on how many comments and even just star rankings we get. So please do us a favor and go over to whatever app you are using, and you will be able to find out how to give us a star ranking or a comment. So now I'll let you get back to the interview. So thanks. Okay, how common now are hepatitis B and C? And let's go ahead and throw HIV in there as well. How common is that? They certainly have been common in the past, at least B and C have been. How common are they now?
Well, when I first started in adoption, hepatitis B was the big deal because there was no hepatitis B vaccine. And parents who were adopting primarily from Korea, where the children got the disease transmitted by their mother at the time of birth, were deathly afraid that their child would be singled out for discrimination because they had hepatitis B, and people would be worried that their children would catch it from them. Mm-hmm. Since there has been hepatitis B vaccine, that problem has essentially gone away. And also with hepatitis B vaccine and prophylactic use of immunoglobulin against hepatitis B at the time of delivery, the incidence of hepatitis B is drastically gone down. So we don't see it very often. We do see it periodically, but generally speaking, it's not a major issue now in intercountry adoption. Hepatitis C is much more difficult to get from a birth parent. So comparing hepatitis B, where you have about a 90 to 95% chance of catching it from your infected mother if you're not treated at the time of birth, it's only about a 5% chance of getting hepatitis C. The other thing about hepatitis C is there's very effective drug treatment now for hepatitis C that can eliminate it. So hepatitis C, while we like to know about it, is not something that we necessarily worry about for the long term. HIV has gone down dramatically with better treatment of pregnant women with suppressive drugs and treatment of newborns. We do have parents that seek out children with HIV to adopt, and it's a chronic disease. These kids generally are doing quite well and have a very good chance for a long and productive life with appropriate medical management of their disease.
How about now moving on to orthopedic special needs? And I believe the most common would be clubfoot or limb or digit deficiencies. How common and what is involved with aftercare?
Sure. Well, clubfoot can be caused by a number of different things. Probably the most common things that we see that result in a clubfoot-like deformity is intrauterine positional problems. So they've got their feet stuck under them in a strange way. There's not much room to move around on the uterus, and so they come out looking like they have a clubfoot deformity, which is really just a positional deformity that usually responds very nicely just to manipulation, physical therapy, and maybe some bracing. A true clubfoot deformity can be caused by a number of different things, but in isolation has a very, very good prognosis. The orthopedic surgeons are very aggressive in taking care of these so that surgery is usually not necessary, although occasionally it can be. There are some very severe types of clubfoot deformity that go along with neurologic conditions that prevent movement in the lower extremities, such as spina bifida, where you don't have innervation to those muscles down there, and that poses a much more long-term problem. With digit abnormalities, many families will have children that have an extra digit on the side of their little finger. It's called post-axial extra digits, and that generally is not something to worry about. They can be taken off at any time by a good hand surgeon and with no long-term disabilities. If you have extra digits on the thumb side, that's much more of a big deal. that require surgery and may be associated with other abnormalities as well. We see a lot of missing digits, missing extremities, amputated extremities from something called the amniotic band syndrome. These are little fibrous connective tissue bands that wrap around developing extremities and digits and auto-amputate them as the child grows and the ligature becomes more constraining. In those situations, what you see is what you get. It's usually not associated with other abnormalities. And if you have a disability, an orthopedic disability as an infant, it's pretty amazing what you can do. People type with their feet. People do very, very well without digits or toes or even extremities when they have the ability to adapt their brain right from the start with the loss of that extremity.
Albinism. I see a lot of that. And when people are asking questions about what common special needs, so I don't know if that it's increasing per se, but what is albinism and what is involved with caring for a child with albinism?
Yes, albinism is a group of disorders that are primarily characterized by the lack of pigment or paucity of pigment. So these kids will have extremely light skin and light hair. Now, most people are aware of the fact that if you have very light skin, you tend to sunburn very easily, and you are at risk of skin cancers. And that certainly is one of the issues in children with albinism. But the one thing that people often don't know is that these children almost always have a compromise on their visual abilities. So these kids can have low visual abilities or even close to being blind in some situations because the pigment production in our skin is also mirrored by pigment production in our retina. And without that pigment production, their visual acuity is not very good. So when you're thinking of adopting a child with albinism, not only do you have to think about protecting their skin from sun damage, but you also have to think about their abilities with vision, because many of these kids are disabled in terms of visual ability, and the need to follow up with an ophthalmologist, not only for the decreased visual ability, but also because they have eye movements called nystagmus that often make the visual disability even a little bit more difficult.
And let's go ahead and talk about vision and hearing loss.
There are a lot of different ways that we see children who are visually compromised. One is that the eye fails to develop. So you have a condition called anophthalmia, which can be either unilateral or bilateral, where the eye never develops, and therefore there's no vision in that eye at all. For some kids, the eye is the only thing that's affected, but remember that the eye is part of the brain and develops as part of the brain. So if you have an abnormality in one part of the brain, the likelihood is that you may have abnormalities in others too. So you can have pretty severe cranial abnormalities. You can have minor ones that affect your endocrine status, or you can have it limited just to the eye. It's important to find out how the brain is functioning in those kids that have anophthalmia.
Are there other forms of vision loss that you see?
Sure, we can see kids with congenital cataracts, which will compromise their visual status if that's not taken care of very early. In pregnancy, we see a lot of kids with strabismus or eyes that don't have a conjugate gaze. They're not tracking the same way. One eye looks like it's wandering. That's probably the most common thing we see. We see it in children very frequently who are premature babies, but there are good treatments for it. And generally speaking, if the treatment for strabismus is initiated in the first few years of life, the visual outcome is pretty good.
Mm-hmm. And we're seeing that children are being treated in their country of origin as well, because this is obvious that they have that they have this issue.
Exactly.
Okay. All right. Now let's move on to talking about urogenital issues. If you could talk about the more common ones, and again, how involved is after parenting care?
Sure. So there are a wide variety of kidney abnormalities. Kidneys are organs that will frequently be associated with both major and minor abnormalities. They're often not known before the child arrives. But for the most part, the urologists that take care of pediatric patients are extremely good about being able to fix almost anything that might be wrong anatomically with a kidney. Of course, there are diseases that may involve other issues, but the one we see most commonly is structural abnormalities of the kidney.
Mm-hmm.
Externally, we see abnormalities of where the urethra exits the penis, for instance, but those can be taken care of surgically. And then we can progress to more severe abnormalities, which involve exstrophy of the bladder, where the bladder is actually exposed and open, or exstrophy of the cloaca, which includes both exstrophy of the bladder and exstrophy of the rectum, too. And these get much more difficult to correct with more severe abnormalities. One of the other things that I would add at this point is disorders of sexual differentiation or ambiguous genitalia. We see these conditions quite commonly. They're very complicated. And this involves not only medical, but social issues as well.
Mm-hmm.
So it depends. Now, there's been a movement, of course, to make sure that sex is binary. We have males and we have females, and many states have enacted legislation to make sure that you can't change your gender after it's different on your birth certificate. Now, the problem is that it's often difficult to know the gender is or how that person will function as a male or female later in life based on what their appearance is at the time of birth.
What about genetic testing? Is that no longer considered? Go ahead.
Yes, genetic testing is very important, but we know that there are people who are genetically a male who are physically a female because they lack the receptor for testosterone.
Mm-hmm.
So the development of the external genitalia, if there is testosterone, that person will usually become a male with a penis and a scrotum. Without testosterone or the receptors for testosterone, the default position is that you will develop as a female. So there are genetic males who look like and function as completely normal females, and there are genetic females who grow a penis because of endocrine problems and look like they are a male at the time of birth. So I think if you are going to adopt a child with ambiguous genitalia, we talk about families being able to step out of the box and take a child who may not be a child that fits into the normal categories.
Mm-hmm.
And I think for ambiguous genitalia these days, that family has to be very special and has to be very knowledgeable about what the possibilities might be in terms of future corrective surgery, how they would live within the society that they are placed, how they're going to be considered, whether they're going to be considered a full person. And the other thing to remember is that some children who are labeled as a male or female with ambiguous genitalia at birth may decide when they are teenagers that that's not who they're going to be. They may feel more comfortable as the opposite gender. Mm-hmm. So I think that parents need to be very open-minded and aware of the issues that have come up in society, not just the medical issues when they're thinking of adopting a child who may have a disorder of gender differentiation.
They have to be willing to live with the unknown because, as you well said, what we're learning now is that we have to wait. I mean, it used to be that immediately they would do a genetic test, and if, depending on XXXY, then they would perform surgery. But we're realizing now by talking with the adults who had these surgeries performed on them, that they're often we've missed it. We've missed what they are supposed to be, because
Exactly.
As you talked, it's far more complex. And I'll also say, I'd be curious to see your experience, but my experience is that these are some of the hardest kids to place because of the, as you say, needing to live with the unknown and allow things to develop as they're supposed to develop. This is not something that you can this is not a problem to be solved. This is a child to be raised.
Exactly.
Yeah.
And I think these kids are very difficult to place. But, over the years, I've seen a lot of families step up and be willing to live with this uncertainty. Although I would say that it's getting more difficult to deal with some of the social issues that have come up surrounding these kids.
And that's unfortunate.
Yes.
For the kids and for their
Right.
parents. Going backwards just a moment, did you talk about imperforated anus? I thought you might have generally hit upon it, but you may have just been talking about the bladder and urethra.
Okay, so imperforate anus is where the anus and the intestine don't meet up. So in baby girls, 80% of them have what's called a low ending of their imperforate anus, which means that there's not very much distance between the colon or the rectum and the anus, and often we'll have a fistula that goes into the vagina or into the perineum somewhere that allows stool to get out. Boys, it's the opposite way. 80% are high. And those kids, the greater the distance between the rectum and the anus, the more difficulty it is to connect them up. So for girls, it's a little bit easier to do a primary repair. For boys, quite frequently, they'll do a colostomy and then repair them when they're a little bit bigger, because you want to get the correct relationships between the rectum and the anus so you have continence of stool. This is a pretty common defect. There are excellent pediatric surgeons around. Again, check where your surgical consultation is going to be. But this is a condition that frequently is taken care of quite well.
And for as far as aftercare, post-adoption, long-term care, do they usually achieve stool continence, or how does that impact? I mean, will these children be able to control their bowels?
Yes, most kids do achieve stool continence with appropriate surgical and post-surgical care.
Let me pause here for a moment to thank one of our partners. It is through the support of organizations such as Hopscotch Adoption that we are able to bring you this podcast. They have been a long-term supporter not only of the podcast, but of creating a family in general. Hopscotch Adoptions is a Hague-accredited international adoption agency, placing children from Armenia, Bulgaria, Croatia, Georgia, Ghana, Guyana, Morocco, Pakistan, Serbia, and Ukraine. They specialize in the placement of kids with Down syndrome and other special needs, so this show is particularly relevant. They also do a lot of kinship adoptions. They place kids throughout the U.S. and offer home study services and post-adoption services to residents of North Carolina and New York. Thank you so much, Hopscotch Adoptions. And now I will let you get back to Dr. Johnson. Okay, we have been talking about physical special needs. Now I want to move to talking about emotional special needs, the impact of trauma. So let's just, that's a huge category, and I think we need to spend some time on it, because
Sure.
We certainly know that the majority of children who are being adopted internationally, well, quite frankly, I would say all, if no other thing, that they have, even if they've been in a very good situation in their birth country, they're being removed from everything they know, even though we would say that's in the long term going to be for in their best interest. It's still traumatic. So let us just say that the vast majority, if not all, kids who are adopted internationally have experienced trauma. So let's talk some about the impacts of trauma on the child. And then I want to move into how much we will know before a child is placed with us about what the child has experienced. But first of all, let's talk about the impacts of trauma in general and the types of trauma you see children, the common types of trauma that you see children have been experienced when they're placed for international adoption.
So the word trauma is used frequently in these kids. And I think we need to make sure that everyone understands that, trauma is not a physical trauma necessarily, although physical abuse can be a traumatic event. But for an infant, not being nurtured is a traumatic event. Not being paid attention to, children who are neglected, children who spend their early life in adverse situations like an orphanage where no one gives them individual care. This all is defined as trauma for an infant. So we know that trauma has effects. And when I talk about trauma, I talk about the three Ps. First of all, the effects of trauma are prompt, they're pervasive, and often permanent. And it depends on how long kids sustain living in an adverse situation. So we know that mental health problems occur your propensity for developing mental health problems develops very, very early if you are in an adverse environment. Growth is affected, your mental health in terms of your externalizing and internalizing behavioral problems, and your cognitive abilities are all affected by being in an adverse environment. So, trauma's bad. I mean, it affects kids universally, and of course, we want to avoid that. The one thing I would say though is getting into a nurturing environment always improves the outcome of kids who have sustained early adversity. So, an adoptive family who's nurturing and who is able to provide contingent, responsive care to their child will help undo many of the issues that come up in that adverse situation that they experienced.
How common is it to get good information in the referral documents so that a parent who's going through that checklist, although honestly, I'm not sure trauma is on the checklist anymore because, as we say, it is so universal. But are parents able to know how accurate is it? Are parents able to know what the child has experienced and how the child has been impacted? Because again, we're not usually talking about infants here.
Right. Well, it's you will often frequently now with referrals coming from the countries that we see active in intercountry adoption, we do know how long they spent with birth parents, institutional care, foster parents, etc. So we can get some kind of an idea of the general environment that these kids have been in. In some countries, and Colombia comes to mind as one of the countries where we have the most information, is that they have a very, very extensive social welfare system that really provides a lot of details on the environment that the child has been in. So we'll often know, what members of the families, what the home life was like. And, in some situations we can tell, this is a child who received was living in a chaotic environment, drug abusing family who basically were out on the street all the time and living as feral children. So we can say with a good deal of certainty that this child has had a long, sustained period of trauma that's going to affect them and need a lot of recovery from. Mm-hmm. On the other hand, we have in Korea, we have a child who's delivered in the hospital at 7 days, went to a foster family, and they've been there for 2 years with very consistent care. And we can know that the environment's pretty good. Kids coming out of foster care, especially if it's been consistent and nurturing foster care, generally look like kids brought up in a family. So I think we have a pretty good handle from most of the referrals that we're seeing now on kind of the environment that a child has been in and how much adversity they've sustained during that period of time. The other thing we can look at is kids who are living in a very adverse environment don't grow very well. So, I think we can look at growth as a measure of the environment and nutritional environment as well.
Mm-hmm. What about the age of the child? We know that children, as I've alluded to throughout this interview, are often coming to us now at an older age as it used to be. You would see infants or young toddlers being placed. But we don't see that as much anymore. And so the kids coming over are very often over the age of 5.
Yes, they are.
So what should parents think about when they're adopting a 5-year-old, a 10-year-old versus a 1-year-old?
Right. So I think you should look at the duration of time that child was in an adverse environment. So there are some kids, and I've met these kids occasionally, who are the true orphans that we used to think about, where both parents were killed in a house fire, and the child survived but was placed in an orphanage at 5 years of age. And they've only been, they lived within a biologic family for most of their life, and they've only spent a short period of time in an environment that would be considered adverse. And I would be very optimistic about how that child was going to do, other than the fact that they lost their parents, and that certainly is a traumatic experience. Or you can have a child who, has lived in institutional care for the entire time since they've been born. And that's a very long duration of adversity. And so I would look at the duration of adversity. And age can be something you pay attention to, but it all depends on where that child has been. The other thing that we know affects outcome is how many changes of environment that child has been in. When we look at growth, when we look at mental health issues, the more that child changes environments. For instance, in the U.S. foster system, they go into foster care, then they go back to the birth parent, they go into foster care, and the birth parent fails again. And so you get kids who are 3 and 4 and 5 years old who may have spent time within foster care, but they've been back and forth and back and forth. Each time that they change the environment, that is a negative effect on that child. So not only the age of the child, but how many times that they've changed caregiving situations makes a big difference in their mental health.
How common is sexual abuse, and how often is that information shared before a child is placed? I will say that children who are without parents or without functioning parents are at high risk for sexual abuse. So how common is it that you see, and then how often is it included in the referral information?
Yeah, we don't see it very often in referral information. We do occasionally get situations where a younger daughter has been molested by an adult or even a father. So that is present in the referral information. But we see a lot of situations where we suspect that there was a high likelihood of sexual abuse, where the birth parent, perhaps engaged in prostitution, would have people come to the house, and a prepubertal little girl is being placed for adoption. We used to say that if you look at the limited amount of data that's available from institutional care situations in Eastern Europe, kids who lived in the older kids' institutions, especially where they were teenagers, very, very high risk, although we never heard it in referrals, of being sexually abused. And it was by the older kids in the orphanage, and boys perhaps more so than even girls were sexually abused. And it could be, as bizarre as it sounds, abuse by caregivers too. So female on male abuse. So, bad things happen to kids that are unsupervised. And pedophiles find situations where they are not going to be detected in institutions. I talked to people who were in the government, and they would frequently root out pedophiles within orphanages because that's where they would go. So if you're adopting an older child, especially a preteen, I think that's something you should think about and be very cognizant about, and look for precocious sexual behavior in the child, just to make sure that you are aware that kind of thing happens, unfortunately.
And have a plan in place to work with the assumption that you don't know and that it is a possibility, and have a plan in place to protect other children in the family until you have had some time to know this new child coming in.
Exactly.
And so, because your obligation is to, and there's a lot of ideas out there for how you can do this. Creating a Family has a lot of information on exactly how to do this. You can search our site for sexual abuse. We also, I always say this when we talk about sexual abuse, because I worry that we're victimizing the victims here when the assumption is that children cannot heal from sexual abuse and that they will become predators. In fact, children can heal, and the incidence of children becoming predators is not that high. So there are definitely things that can be done, but you do need to be aware going in about the possibility. And again, we have a lot of resources on our site about how to help kids heal from sexual abuse. All right, now an area that is near and dear to creating a family, and that is prenatal substance exposure, alcohol or drugs. We have a lot of information. This is extremely common in the U.S. foster care system and even outside the foster care system. But even with domestic infant adoption, the incident is higher than average. So how common is it in the children you see? And then in our next section, we're going to we'll talk about what are the most common special needs by country, and you can address each country. Okay, but just in general, how common is it? And what are the impacts? And what do parents need to think about, both for the short and the long term?
Well, I think that substance exposure within the group of kids coming for adoption is probably similar to what we see in the United States.
Our foster care system, you mean?
Right, exactly. So we do run into it very commonly. So there are lots of drugs that people can abuse. Many are illegal, some are legal. And ironically, it's the legal drug, alcohol, that seems to be the one that affects children the most. The difficulty of saying anything definitive about an exposure is that people rarely use one drug. They're often, drinking, they're using cocaine, they're using narcotics, and they're also living in situations that they're not getting good nutrition, they're not getting good prenatal care.
High stress.
They're poor, high stress. So there are many, many factors associated with substance abuse that are independent risk factors for outcome for these kids. So, there are no scientific studies of, upper middle class women who got good prenatal care and who used cocaine every day. So we don't know what the independent effect of cocaine might be 30 years down the road in terms of mental illness, cognitive behavior, et cetera. There's a whole mishmash of things that are impacting our follow-up studies of these drugs. So I think, a couple very broad points. One is if you're concerned about a drug, be concerned about alcohol. Maternal alcohol use can cause significant malformations. It can cause significant brain damage, and it can affect long-term mental health and cognitive abilities in mothers who use frequently and in large amounts. The other drugs that we often think of, there's not as much data about them. We do know that there are effects that are associated with drug use, but there are a number of studies, and some of them are good, some of them are not so good, and it's very difficult to predict on an individual basis how mother's chemical use during pregnancy is going to affect an individual child. Mm-hmm. The most important thing to remember is that no matter what the issue is, a nurturing, loving, responsive home makes a huge difference in outcome. So if you look at the number of studies that have looked at general adversity, drug exposure, et cetera, the difference between growing up in a birth family versus growing up in an adoptive home make a huge difference in terms of the outcome. So, I tend to look at the world through rose-colored glasses. And I'm very optimistic about many kids who have had exposure. Kids with alcohol exposure, especially if it's been heavy, I think families need to think very hard about whether they're the right parent to take care of their child. But I think since it's so common to be exposed to drugs or substances during pregnancy, I think optimism is justified for most of the situations.
I will say that Creating a Family has a workshop for parents. We actually have a workshop for child welfare professionals as well, a separate one. I can't recommend it highly enough. It is an interactive participatory workshop. We offer it numerous times a year. You can get information on our website. I should say it's a workshop for parenting children who've been exposed to alcohol and drugs. And we cover specific techniques, evidence-based techniques that work with these kids.
Let me just add one more thing, Dawn.
Sure.
Is that, you can go into this with your eyes wide open and be optimistic, but realistic at the same time.
Yeah,
exactly.
So
I think that, saying, oh, the family and good food is going to take care of all the problems my child had, which was the mantra maybe 30 years ago, is now your nurturing environment and a good diet goes a long way to making sure things are fine. But what you have to be aware of is that there may be issues you have to deal with. And it's important at very critical points in life, such as before going into kindergarten or first grade, to get a full evaluation of your child's abilities and their needs, so that teachers, psychologists, et cetera, within the school system or whatever educational system you're going to put them in are aware of some of the weaknesses that your child may have and can design a program that will allow your child to become the best possible person that they can be.
And I would add, not only in a school setting, but also as in the home setting, you may need to change the way you are parenting for this child to become thrive and grow to their potential. But the good news is that there's lots of information. Creating a Family has tons, and that's what we do. Most of it is how we can parent kids who've experienced trauma or abuse, neglect, whatever. But there's lots of other resources available too. So how can parents, adoptive parents, support and advocate for children who are discriminated against due to physical, cognitive, and other disabilities? Because that's also, when you have a child in your family who has a disability or a emotional or behavioral disabilities or behavioral issues, part of your job as a parent is supporting and advocating for that kid.
Well, exactly. And, parents may think, well, I'm just a parent. What am I going to do to change the school system, to change society, to change how the government looks at things like this? Well, let me just put a little history into this. Back in the 40s and 50s, parents who had children with Down syndrome would frequently put them with institutional care because there really was no place for them in society. But because parents banded together and advocated for their kids, there were two seminal pieces of legislation that came about. One was to make sure that every child got a free public education that was appropriate for them. And the other was the American for Disabilities Act, which allowed kids to participate fully in society. And that was all done because parents of children with disabilities banded together and made their kids visible. So I think making your child visible to your school system, to your church, to your community, to whatever, to make them a human being, to let them know what a wonderful individual they are, that they have the right to services, that they have a right to have all the experiences that every other child has, is extremely important. So I would say make your child visible to every area in society and let them know that they're valued and that they are a full participant in the world as we know it.
And I would also throw in that if you adopt a child with any of the disabilities that we've talked about, or any of the emotional or behavioral challenges that we've talked about, your job as a parent is to learn as much as you can about that disability so that you can advocate even in the medical situation and in the school situations that you're educating. One of your jobs is to educate the world about, and sometimes, sadly, even your doctors, about what is best care or what you are reading about what is best care and getting information. You can't just be passive.
No, you can't. And I would add, on a personal note, I have met many a parent of a child with a disability who knew infinitely more about that condition than I did. And woe to the physician. And you have an MD and a PhD, okay? and woe to the physician that ignores parents who have spent their life advocating for their kids.
Amen. Okay, we're going to pause one more time, but make sure you stay with us because after the break, we're going to be doing the rundown of the most common special needs by placing country, the most common placing countries. But before I do that, let me tell you about and thank the Jockey Being Family Foundation for their support of this podcast. Lo these many years. Thank you, thank you, thank you, Jockey Being Family, for that. And it's through their support that we're able to offer you 15 free courses. You can utilize these courses for continuing ed if you need continuing ed, because you can get a certificate of completion. But even if you don't need continuing ed, these courses are just terrific as far as helping you be just a good parent. You can find these courses at bit.ly/JBF support. That's bit.ly/JBF support. And now back to what I promised you, the rundown of the most common special needs. All right, now we're going to do a rapid fire going through the top placing countries and having you tell us what are the most common special needs you see right now coming from those countries. All right, Let's start with India.
India, by far, premature babies or low birth weight babies are among the most common kids that we see, or kids with a variety of congenital malformations.
Okay, and how common is prenatal alcohol or drug exposure?
We don't see it very often. It's almost never a part of the record. We don't see the facial features of fetal alcohol syndrome very often from India, but we know that the drinking does happen. Mm-hmm. And so not all kids with fetal alcohol spectrum disorder have the facial features.
In fact, most don't. Yeah.
Right.
Okay, now Colombia.
Colombia, we see very complicated family situations, lots of drug abuse and dysfunctional families for a wide variety of reasons. Very, very long, detailed social history for these parents. And also we see kids with extremely complicated medical issues.
Okay, Bulgaria.
Bulgaria, I would say the usual spectrum of congenital malformations. But anywhere in Eastern Europe, we do see a large number of kids that do have the facial features of fetal alcohol syndrome, or may have the behavioral issues that we might see.
Ukraine, although we're not seeing the numbers come from there right now, but
right. But again, I would say the same issues for fetal alcohol syndrome.
Okay, South Korea.
South Korea, it can vary. South Korea has a very robust medical system that generally can take very good care of their kids in terms of surgical needs and things like that. Cognitive disabilities and developmental delays are very, very common. Prematurity, but kind of a potpourri of congenital anomalies too.
How common is prenatal alcohol or drug exposure?
Well, we do see it. One of the interesting facts is that as we've gone through the years of adoption, when we first started, women using alcohol was such a forbidden thing. Mm-hmm. We didn't see fetal alcohol syndrome. Now with more common use of alcohol by young women, we do see more alcohol exposure. Mm-hmm. We see binge drinking, which is usually documented. So we do see fetal alcohol syndrome and spectrum disorder in those kids.
Okay. How about Haiti?
Haiti is a mess right now. And the kids, by and large, extreme deprivation and trauma from the environment that they're living in. We do see both severe and straightforward medical problems simply because there's no infrastructure to take care of it in Haiti at all.
Mm-hmm. And last, which is a huge lumping of a large number of countries, but African countries in general, because I think they have some similarities rather than breaking them out individually.
We see few kids from Africa. I would say the majority of them are very similar to what we see in other countries, where it's a mix of kids who were abandoned and have been in institutional care, or kids that have various congenital malformations. Alcohol is also commonly used in Africa, and so that would be a possibility too.
Okay. Well, thank you so much, Dr. Dana Johnson, for being with us today for a whirlwind tour of the common special needs in international adoption. We truly appreciate your expertise and your wisdom. It is so helpful, so thank you.
Thank you, Dawn. It's been a pleasure.